Good morning, everyone. The Unit-Based Safety Council has decided to look at our use of physical and chemical restraints when caring for the agitated patient. According to Richmond in 2012, the Joint Commissions and Center for Medicare and Medicaid look at low restraint use as a quality indicator. Patients are often anxious and frightened when a surgical intervention is needed. The presence of underlying mental illness and the unknown effects of anesthetics can exacerbate their anxiety and result in violence. Our goal is for our patients to maintain safety as well as our staff and visitors. What is verbal de-escalation? Richmond in 2012 defined verbal de-escalation as the act of verbally engaging the patient to enable them to regain control of their emotions. Think of this as calming your patient down or helping your patient calm themselves down. Richmond in 2012 suggests learning to develop a verbal loop with the patient, which allows us to listen to the patient, find out why they are upset, agree or validate their position, and then communicate with the patient what we want them to do to remain safe. It is not uncommon to have to repeat what you would like for the patient to do several times when they're upset before they actually hear what you're saying. Richmond also points out that once mastered, verbal de-escalation techniques can be successful in less than 5 minutes. A few of the techniques we will work on: space. Give the agitated patient space. One example is 2 arm lengths of distance between you and the patient. Tone. Use a calm tone when talking to an agitated patient. De-escalation. Learn to develop that verbal loop. And documentation. Accurately document when you've had to use de-escalation techniques. Why should we be required to learn verbal de-escalation strategies? Well, Tischler in 2013 suggests that there is a link between having adequately trained staff and lower incidences of violence in patients. This could simply be because staff can recognize symptoms, know the risk factors, and know how to avoid potential triggers. Richmond in 2012 suggests that using force to subdue a patient actually reinforces the patient's perception that force is necessary. In their article, Violence and Mental Illness, Reeve and Oeltjen in 2008 point out that as healthcare workers, we must be aware that a patient's violence may be triggered by their hallucinations or delusions. They may feel that we're trying to harm them. And finally, in 2010, the Joint Commission supported healthcare workers learning de-escalation techniques. When are we going to start this? We're going to begin scheduling existing staff to attend mandatory training over the next 2 weeks. Upon completion of the training, we will begin practicing de-escalation techniques immediately. Training will be provided to any new hires, and training sessions will include an introduction to the techniques and then role-playing so that we become more familiar with interacting with agitated patients and we can just feel more comfortable with that. We will trial this for a 3-month period. We ask that staff accurately document all incidences involving agitated patients in the EMR. If you used a de-escalation technique, whether or not you were able to calm the patient down, and if physical and chemical restraints were used. Matley in 2016 reminds us that accurate documentation allows for the analysis of data which can lead to quality changes that improve patient outcomes. The UBC will measure the data utilizing these techniques to see if it provides a benefit to our patients. Please do not hesitate to ask for questions while we implement this strategy. Thank you so much.